Many patients who are considering TMS therapy for treatment for their depression look into the side effects of TMS, and they want to learn more about what kind of side effects that they should be expecting, if any, with transcranial magnetic stimulation. All right, so you can find this page on our website. Okay, all right. So what are common side effects that could happen with TMS therapy? The very first one, which is very common, is scalp discomfort. Okay, so the idea of TMS is that we want to stimulate the brain, but we do not want to use electricity. We use magnetic pulsations. Those magnetic pulses, when they're traveling from the magnetic coil down to your brain tissue, on their way, they will activate some of the scalp tissue in here. And that will cause a little bit of discomfort. Okay, so that's basically what it is. A lot of patients just describe it as mild tapping sensation on the side of the head. There are some patients who are a little bit more sensitive, and some of them, they don't like really that tapping sensation on the side of the head. Rarely, like every 20 patients, I might have a patient who would think that this is prohibitive for them to continue TMS therapy. And in such a situation, we stop TMS therapy. In other methodology, we could actually give them over-the-counter medication to help some with this discomfort, or we could lower the intensity gradually and work our way up over time. All right. The second from the most common side effects of TMS therapy is facial twitching, okay? That goes with the same principle that we were talking about. While the magnetic stimulation is making its way through your skull to your brain tissue, it might activate branches of the facial nerve, and that could cause twitching. Sometimes patients will wink in their eye. Sometimes that winking would be on the other eye because we're putting the coil in a way that is pointing towards the middle center of the brain. So, they might feel it some on their right eye or in the tip of their nose. So this is very common as well, all right? The third one that is common is headache. Remember when we said scalp discomfort? All right, so some patients, this scalp discomfort could increase in intensity to the point that it feels as a headache, or they would have a headache. Now, I want you to understand here that this headache is closer to a tension headache kind of properties. Let me try to give you an example in here and see if that would make sense to you. Imagine if you were driving a car, you went out of town, you're in a new city, and you decided to rent a car. Now, the car that you're renting most likely is not the classical or the car that you always drive that particular vehicle. So the seat is going to be a little bit different. Until you make adjustments of the seat and what have you, you're driving for multiple hours in this new car, you might have some neck strain that could happen in the back of your neck. Now, if that continues for an uncomfortable period of time, you might end up with a headache. That headache is usually radiating. You feel some tension. That's where the word tension headache comes from. And that usually is a little bit different than what you would experience with migraine headache. And that's important because when we go down to the myths of TMS therapy, okay? So yes, headache is a side effect that could happen with TMS. Usually it's during the treatment session, maybe up to about half an hour after the treatment. We can try to avoid that headache by taking Tylenol about half an hour before the treatment. Ibuprofen, if you don't have a contraindication for ibuprofen, meaning that you have a good kidney function and you don't have stomach ulcers or sensitivity to NSAIDs, which ibuprofen is one of them. Okay. All right. So the common side effects are going to be scalp discomfort, some twitching of the eye, that's temporary, only when the pulse is going on, right? So you're on the magnetic coil is going on, you're going to twitch a little bit off your eye. When it's off, right? And then some patients, they will twitch in their eye and they don't know they're twitching in their eyes. This would be me and the treater who are seeing that they're twitching in their eye. And it's not like it's going to cause a tick or something of the sort. That I've never seen it reported. Okay. All right. Now, what are the uncommon side effects of TMS therapy? All right. Now, rarely a patient could go into manic or hypomanic episode. Okay. So remember how, we're treating major depressive disorder, mood is low, things on the lower side, etc., etc. Every now and then, a patient might not report a previous manic episode to their doctor, or the doctor is treating somebody with bipolar disorder who is in a current depressive episode with TMS, or somebody did not really have any manic episode before, but their diagnosis is actually, or the underlying pathology is actually bipolar, and now the TMS activation, the stimulation of their brain with TMS will push into a manic episode, okay? Now, that does happen, okay? Now, what if it happens? Is it the end of the world? Not really, okay? So if it happens, then we just need to stop TMS treatment and follow up on the patients and see what happens with them. So the cases that I usually have when patients will go manic or hypomanic with TMS, it would be that the patient will become more insomnic. They would not be able to sleep for like, 2 to 3 nights in a row. And then they will have a little bit of irritability or a little bit of agitation that could happen. Now, the patient is coming in on daily basis for their TMS treatment. Most of the times, they're going to report that to the technician, to the TMS technician. So the staff will know about it, or they will notice that the patient is becoming a little bit more nervous than usual and stuff of the sort. That will warrant the evaluation by the physician. So I will go see the patient and see what's going on. I'll hold TMS treatment for a few days, and then I will see the patient again. If those irritability and lack of sleep symptoms went down, then we'll open a discussion with the patient. Do you want to be re-challenged with TMS again, or do we not want to be re-challenged again with TMS? Because this could be a temporary thing. So in that situation, I have patients who would elect to actually be re-challenged with TMS. So we'll try TMS again. Now, if again, they're not able to sleep and they're getting a little bit hyperactive, we definitely don't re-challenge again. Okay, it's over. Okay, so this person is going to be overactivated with TMS therapy. Okay, if a patient did not really get more hyperactive, did not really, have insomnia again and stuff of the sort, then we continue with the treatment without an issue. Now, all of this, know that TMS therapy currently is FDA cleared for the reason of major depressive disorder, not for the reason of bipolar disorder, okay? So those are two different discussions. Side effect of TMS causing manic or hypomanic episodes, which is really rare, but it could happen. And then the other discussion is that if you have a patient with bipolar disorder who is currently in a severe depressive episode, can you actually do TMS for them or not? Is it a contraindication or not? Per insurances, because insurances don't want to pay money, they would say it's a contraindication. In real life, as long as you're monitoring the patient to not switch into a manic or hypomanic episode, you can challenge with TMS and see what happens. And there are plenty of data and studies on that in the past. Okay, another uncommon side effect is problems with hearing, decreased hearing, okay? Well, also tinnitus or tinnitus, okay? So I put both of those into the same category, okay? So when you're receiving your TMS treatment, the machine that we put, like the coil that we're putting on the left side, for the dorsolateral prefrontal cortex, so the machine is going to produce loud noise. So it goes into those waves that will make a noise, and then it stops and it goes again. So if we're exposed to this loud noise for a long period of time, we might have tinnitus or tinnitus, depending on whether you speak English from the UK or from America, okay? And that's basically ringing of the ears. So, and that basically is related to the fact that this vibration will travel through our ear canal, and it would go to the tympanic membrane, and that could cause damage, for our hearing sensors, okay? So what is the solution to this problem? Wear earplugs, so we give our patients foam earplugs, they put them in their ears. When they're done, they throw them in the trash. In clinical trials, patients who actually wear the foam earplugs, they do not have this problem with tinnitus, tinnitus, or decreased hearing, or anything related to loud noise in such a situation. And this, by the way, also is the same recommendation that we have for patients who would go through an MRI of their brain or something of the sort. Okay, another rare side effect, syncope, okay? So syncope is the loss of consciousness, particularly when the patient is in a standing up position, right? Now, syncope is different than the seizure. We're going to get to the seizure as a side effect, all right? But I noticed that the vast majority of patients who are talking about pre-syncopal symptoms has nothing to do with the TMS as a fact of delivering magnetic pulses to the brain. It's mostly because the way that we adjust the chair and we put the chair. So if you remember with TMS, we need to put the coil, basically pointing to the center of the brain. To achieve that without really putting too much weight on the coil in a certain position, instead we recline the patient, and that will put the patient into a more comfortable position. So the patient will recline back, similar to a dentist chair, okay? And then we're putting the coil on the side of the patient head. Okay, and then sometimes we need to elevate the chair to make the contact between the coil and the patient head, okay? So now you have your patient who was sitting up, tilted backwards and raised up. And when we're done with the treatment, we're adjusting the patient position to where they were before. There are some patients who are sensitive to this orthostatic change, okay? The change of gravity that happens, and they might feel lightheaded. So I tell my patients, usually this is something that we need to watch out for patients who have POTS, the abnormality of heart rates for some patients, elderly patients who are sensitive. Now, next one is the big one, seizure, okay? All right. So if you remember, we don't intend to cause a seizure with TMS. Seizure is something that we do with ECT, not with TMS. We do not intend to create a seizure in the brain with TMS, okay? But rarely, which is 1 in 30,000 treatments, a patient could actually go into a seizure. All right. Now, the important factor here is that most of those reported cases of seizures happened for patients who either had head trauma before the TMS treatment, or patients who had seizure disorder before, or patients who are withdrawing from a hypnotic medication or alcohol just before they started the treatment. So it's as if TMS on its own might not be powerful enough to cause seizures for anybody, but if you had an underlying condition that could predispose you for seizure, then there is a little bit of a high risk of seizure in this situation. But despite all of that, the rate of seizure reported in the initial pivotal trials for TMS is 1 in 30,000. Okay, now here's the caveat. Later on in post-marketing studies looking at actual seizures that happened in TMS clinics, it was only 1 in 89,000 treatments. Okay, so the actual rate in real life is significantly less than what we thought of during the clinical trials for TMS. It's 1 in 89,000 treatments, okay? And to be quite honest with you, in clinical research, there are a lot of neurologists who use TMS to treat the motor cortex, so there is this recommendation of a sort to kind of use TMS for peripheral neuropathy, for neuropathic pain. And one of the target areas is M1, it's basically closer to the actual motor cortex. So, obviously stimulating the motor cortex carries higher risk of seizure than stimulating the frontal lobe, okay? All right. So because of all of this, I want you to know that the risk of seizure is so extremely rare to the point that it's negligible, okay? I don't have an actual seizure that ever happened in our 2 clinics, 3 treatment chairs, okay? I've been practicing TMS since 2019, all right? Now, what do you do if you had a seizure during TMS treatment? You just turn off the device. The seizure will stop in about half a minute to 2 minutes, similar to the man-made seizure that we do with ECT, right? The goal of that is to have a very short period of seizure. So it's self-terminating seizure usually, okay? And you still need to send the patient to the hospital. You call 911 and all those kind of things just to make sure that they have appropriate workup for a seizure disorder after, the seizure that they could have happen. But again, I don't have a real case that I can share with anybody that we actually needed to do any of those things. And we are one of the high volume clinics that does TMS. All right. Now, let's talk about some myths that people associate with TMS. Okay. All right. So the first one to debunk is TMS could have a problem on cognition. No, TMS does not cause memory loss. End of the story, okay? I do understand, subjectively, every now and then somebody would say that they had memory problem with TMS. I do understand that. But if you look at most randomized control trials that looked at cognitive function between the groups that went through TMS and the group of sham or the group of placebo, the group that went through TMS had improvement of their cognition compared to the one that went through sham or placebo, okay? All right, so if we are going to point to any correlation between TMS and memory, and cognition, it would be improvement, not decline, okay? Despite that, we cannot really make a conclusive evidence that we can actually use TMS yet at this time. We cannot really make such a claim that we can use it for Alzheimer's disease, or we can use it for brain enhancement, human enhancement to make people smarter and stuff of this sort. Why do I say that? Because patients who do have depression, associated with that, they will have cognitive issues. They will have memory issues. Think of that person who is severely depressed. They're probably not going to be very sharp in their memory. Based on that, if we treated a group of patients who do have severe depression, a percentage of them, their depression is going to get better. And when it gets better, they're going to improve in their memory as well. Okay, so I cannot really say it's a causation that TMS made, people's memory better or their cognitive function better. It might be correlation because we're treating the depression that was causing the pseudo dementia. Okay, all right. Okay, the other thing is that if you think about it, we're stimulating the frontal lobe. So the frontal lobe, the dorsolateral prefrontal cortex, we know its involvement with depression and stuff of the sort, but also that area of the brain in the frontal lobe is responsible for our ability to process information. That in stimulating that area could enhance our cognition and memory. So the first one that we debunked is that TMS does not cause memory loss, okay? The second one is brain damage. TMS does not cause brain damage, okay? I repeat, TMS does not cause brain damage. Now, there is zero evidence that is validated that the current methodology of TMS that we use causes any brain damage, okay? TMS is magnetic pulse. It's not an X-ray. It's not a CT scan. Okay, so those things that you hear about, like imaging and causing problems to the tissue, those happens with those kind of imaging. Do not happen with an MRI. Okay, all right. So the TMS is more closer to an MRI in the terms of what we are exposing our brain to, and so far we don't really think that this causes any substantial brain damage. I want you to be thinking of electromagnetic pulse, right? Electromagnetic means that electricity produced a magnetic pulse, then you're receiving that magnetic pulse, translating that again to electricity. Think of this similar to your cell phone signal, okay? So your cell phone signal is basically electromagnetic pulses. The 5G network that you're relying on, there is a tower that is producing a magnetic pulse. It's received by your phone. It's translating that magnetic pulse back into electrical signal, and that's how you have data, and that's how you're talking with people. Okay, now, could somebody have sensitivity to electromagnetic signals? Yeah, I know that there are a lot of social media talks about that. We don't really think that this is a real disorder yet, okay? But it's one of those things that people talk about. So if there is a damage from electromagnetic signal to the brain, your phone should be on your top priority or on your top risks, not TMS, okay? And if TMS is going to actually stimulate your brain in a therapeutic fashion, you're not going to stay away from it because it's electromagnetic signal. This one does not treat anything. Maybe get away from that, okay? Another thing is radio signals everywhere, right? Like, radio that we used to listen to and what have you. That is also electromagnetic pulses, right? Everything around us, like you cannot really escape that, and I'm saying that with huge amount of empathy for patients who do have electromagnetic sensitivity disorder. I don't know what it is being called nowadays. It really sucks if this is your life. I do understand how this could be terrifying, but in the real practice of 99.9999% of the population, we are living within this, spectrum of electromagnetic signal, and we're surviving it as far as I know. Okay. All right. So again, there is no evidence, clinical evidence, that the intensity of magnetic stimulation that we use for the reason of TMS causes brain damage. All right. The third one is migraine headache. Now, this one is a little bit questionable, okay? Remember how I told you it causes headache, but what kind of headache it causes? It causes something closest to tension headache, okay? Now, why did I put that, migraine headache into that this is a myth? There is a device, I think it's called Spring TMS, I want to say, and that device is actually indicated to abrupt an episode of a migraine headache if it's delivered during the aura period of the headache, okay? All right, so let's say that somebody has migraine. Usually they will have a little bit of an aura, usually visual or smell or something like that before that. They know that the migraine headache episode is going to happen. They will take that device, which they will put on their occipital lobe of their head, and they will deliver one pulse. Okay, and if it doesn't work, they can do it another time. I think there's a limit for how many pulses they can do, but you can deliver a pulse, and that will abrupt, the episode from developing into a full migraine headache. And that, by the way, does have an FDA clearance. The manufacturer, I think, is called eNeura. Okay, and I have it here in the slides. Okay, have plenty of references in there. Okay, go ahead and investigate them, read about them, see everything that is put there for side effects of TMS. Tell me if I'm wrong on anything. Please be nice in the comment section. Okay, all right. Tell me, what do you think? Are there any of these side effects that you think, people are experiencing more than others and stuff of the sort? We would like, to kind of hear your own experience. Thank you.